Okay, now.
Thank you. Thank you very much. Very good afternoon from people watching this talk in London, and good evening to cardiologists in Bangladesh. And many thanks, Professor Shajol Banerjee, who is my teacher and is a convener for this, and Professor Nazrul Islam sir and Professor Fazlur Rahman sir. And Shahila Nabi is actually the moderator for this program. We studied in same medical college in Bangladesh. And COVID-19 coronavirus has distanced us socially, but COVID-19 couldn't distance us professionally. We are actually far closer in professionally when COVID had started. And I do not have any conflict of interest with this talk. And let us start. This is a small study, a European study, around 5,000 patients and distribution of valvular heart disease in the EuroHeart study. I think probably you can see the reference in, it was published back in 2003 European Heart Journal. What you can see here, then around 34% patient actually presented with aortic stenosis, around 10% patient is native valve disease, 10% with aortic regurgitation, and mitral stenosis is not very common, and MR and AS is these two biggest challenge in European countries. And so let's focus on what are the common causes when you see a patient in aortic valve. For aortic regurgitation, the common way I have split it in two portions. One is a valvular problem, is problem with the valve itself. You can see bicuspid valve. This is very common in Western world. And rheumatic valve disease, we don't see very common. Rheumatic valve disease, I think probably it is more prevalent in Indian subcontinent, Bangladesh. And we see degenerative heart valve aortic regurgitation is much common than rheumatic disease. Then endocarditis we see is more commonly in and acute causes. If you look at the images here, that one in and it's a tricuspid calcified aortic valve. On the right, it is a bicuspid aortic valve and calcified bicuspid aortic valve, and this is a rheumatic aortic valve. And bottom, this one is somebody has got perforation is because of infection and because of infective endocarditis. If we look at the other reasons of why we see aortic regurg in our hospital, there is a problem with aortic root. It could be dissection. It's because of hypertension, high blood pressure, and Marfan's. And if you look at this one, this is an hourglass shape. This is somebody who has got Marfan syndrome and presented in hospital with aortic regurgitation. So what happened? And this is because of the heart valve. That valve makes the heart sick. So this is actually out. So this is a primary cause. And if you see the other group, aortic root dilatation, that other causes that make the valve sick. So we commonly see aortic regurg, one group because of the heart valve problem itself, and other group is because of the other causes causing valve giving pressure. Let's refresh European Society of Cardiology guideline published back in 2017. And what's new in this guideline? What they have suggested to use of transesophageal echocardiography to evaluate the results of surgical and percutaneous interventions, because percutaneous interventions are gradually become more more in practice, and also suggested that CFR is considered useful when echocardiographic studies are not optimal, especially volume, and also suggested the MDCT with ECG synchronization when surgery is proposed. And what is the questionable aspect of that guideline published back in 2017? And that criteria for aortic valve repair or replacement poorly defined. I think when the working group are sitting next time, I think probably they will be focusing on more, because aortic valve repair gradually become popular. The committee will need to think more update with new guideline. So let's talk about the American Society of Echo guideline. And if you see the American Society, that's also published back in 2017. What is new there? And actually, they have emphasis on etiology and mechanism of aortic regurgitation. During my talk, I'll slightly talk about a couple of slides for a mechanism of aortic regurgitation, and also is actually integrated approach of 2D and 3D thoracic echo, and also transesophageal echo where it's needed. And also that guideline emphasis on CMR. So just before going to any kind of images, let's refresh our knowledge on what is European Society of Cardiology guideline about the management of aortic regurgitation. You might ask me, Monjur, why you have put this slide before showing any kind of images or any echo? But the reason I put this slide at the very beginning, because when you start assessing valve, at the end of the day, your focus would be like, who are the patient of mild AR, who has got moderate, who has got severe, and who need actually urgent surgery. So if you look at this slide, significant enlargement of ascending aorta, and it is indication, class 1 indication for surgery. And now look at that, somebody that don't have significant ascending aorta, but severe aortic regurgitation, if that patient is symptomatic, as again fall into class 1 surgical indication. If somebody doesn't have symptoms, and these are the most challenging group, and what you see actually, left ventricular ejection fraction is less than 50%, and LV, left ventricular end diastolic diameter 70 millimeter or more, or LV and systolic diameter 50 or more, and millimeter or more, and body surface area. So you can see that this is the most challenging group. This is the reason I actually put this slide here. Because when you see this patient didn't have any symptom, but the patient is actually, when you're actually assessing valve, these are the few points you need to take it very seriously. If you find one of these changes, that and that patient actually need urgent surgery, surgical referral. And there is no dispute when you say guidelines is class 1 indication, and all other the severe aortic regurgitation and no symptom, you actually, like you do need to follow up, routine follow-up. Some does in 6 months, some does in a year. It depends on how you are practicing. When we start assessing aortic valve, what are the things we look for? We need to document what is the body surface area. We need to document heart rate, heart rhythm, blood pressure. Putting down blood pressure is so crucial. If you have actually, if you have somebody have got wide pulse pressure and your assessment, you got severe aortic regurgitation, that patient actually outcome might be poor. And also, I already discussed about talking about etiology, then valve morphology. Actually, when you start assessing any valve, how many cuffs there is, a tricuspid valve or is a bicuspid valve? Is there thickening? Is there any restriction? What is the doming? Any prolapse, calcification? And then you need to look for jet direction and origin. What the jet is coming from? Is it central? Is it fan out centrally? And is it eccentric? Is it commissural? Is it ascending aorta dimension? These are very crucial when you actually assess valve. And severity. And there is, they need to be very integrative approach. There is not any single method, and you can say, oh, this is the best method for this valve. So you need to assess on vena contracta. I'll talk through vena contracta, pressure, heart time, flow reversal arch, and also LV dimension and function is also important. And again, emphasis is this is the most challenging group, chronic severe AR. LV is almost always dilated, and surgery is recommended as class 1 indication I mentioned. The AR on end diastolic diameter is 70 millimeter or more. LV internal diameter is 50 millimeter or more. Ejection fraction is less than T. And now mechanism, I mentioned that I will talk about a little bit about mechanism. Type 1, type 2, and type 3 is almost like Dr. Gobin showed mitral valve mechanism. It's almost aortic valve mechanism also we are actually doing. Try to find out what kind of mechanism is actually present in this valve. There is 3 types. In type 1, where you see normal cusp motion with aortic dilatation, you can see the aortic and cusp perforation. There is type 2, there is, you can see clearly cusp, and type 3, cusp restriction. And the reason I put this slide, I think I'm not quite sure about what are you doing any repair of aortic valve? If not, when you actually start repairing valve in Bangladesh, probably you need to think about, you need to actually find out the mechanism of regurgitation. Like this one in type 3, this is very, you cannot repair that. On prolapse and type 1 and type 2, it is repairable. You can actually save valve. Now, moving to next slide is again in the guideline that says when an aortic root diameter is more than 50 millimeters. Now, going to this echo now. This is one of our patients who was actually came to our hospital because of on examination we found he has early diastolic murmur. And on scan, you can see he never had any kind of problem. And if you look at his, this is left atrium, this is mitral valve, this is aortic valve, and this is LV, and this is RV. When you look at his LV, it looks a very big dilated LV, and he never had any kind of problem. And only one thing, when he met his GP, he told us he has got big dizziness. And this is how it's a long extending actually hypertension, actually one of the causes for aortic regurgitation. When you get anybody with aortic regurgitation, we need to start with measuring. And I think probably you might have different opinion. The thing I'm trying to say now, you need to do internal to internal edge when you actually measure diameter. That is our practice. When we assess any valve, we need to do internal inner edge to inner edge. And when you actually doing a mid-systole, when you actually measure, you need to measure during mid-systole for annular measurement for sinus and sinotubular junction and ascending aorta. You need to do in end diastole. And so this is how we do. And if you read European Society of Cardiology or American Society of Echocardiography, their guideline, in the guideline they have mentioned measuring leading edge to leading edge. The problem with the measuring from guideline leading edge to leading edge, the problem because more and more we are actually comparing our echo data with other imaging modalities. For instance, we are actually comparing validating our data with CMR. So if you actually, if you look at read the guidelines, how in CMR and other modalities, they are actually measuring diameters inner edge to inner edge. So this is one of the biggest limitation of European society. You have to compare your data with CMR. So I would recommend you to measure in inner edge to inner edge. This is I think there are lots of fellow attending this conference. So we need to be familiar with all this kind of way how we actually assess valve. So the apical window, left parasternal window, supraesternal window. This is also very useful, and I'll go to that slide. So why it is so, and also subcostal window is actually quite useful. And we are actually, when we assess valve, we need to try to apply as much as possible. So, and also when we actually measure diameter, remember one thing, that when LV dilated, it dilated actually in more of a spherical fashion. So sometimes it's very tricky. Actually, if the measurement is not correct, then obviously you'll be correcting wrong volume. So
Doctor,
that's volume.
There are 2 minutes left, so please start 2 minutes left. So please start wrapping up your presentation.
Okay, so this is with the bicuspid aortic valve. You can see dilated ascending aorta.
Okay, sir.
When you actually assess somebody, young hypertensive patient with dilated aorta, you need to go a bit space higher, otherwise you will miss dilated short-term ascending aorta. You can see on this slide, you see they also have developed coagulant aorta. This is associated. Moving. So another important thing is like when you actually do assess valve, you need to focus on like aligning your probe on the flow. So if it is what normally we expect, not more than 30 degrees, ideally 20. If it is 90 degrees, actually aligning your probe, then you will actually not get any flow. So it is so when we assess aortic regurgitation, we need to look for a few things for that. Looking at the pressure half time. vena contracta, effective regurgitation of this RV volume. So this is one of the slides. Lots of people actually assess in a mode, color and mode, and what people think about it, less than 1/3 of the diameter width of that and think about it severe. And if it is more than 2/3, then it is severe. That's the problem with actually you overestimate central jet and underestimate eccentric jet. And this is a vena contracta. The way we assess vena contracta, we need to look down the flow convergence. You need to go to and then the vena contracta is the narrowest portion of the flow coming back to left ventricle or through the aortic valve, and you need to look at the jet area. So this is actually quite important. So you need to set up Nyquist limit 50 to 60 centimeter. If it is narrower, less than 3 millimeter is mild. If it is more than 7 millimeter is severe. And now the pressure half time is another important thing. When actually, pressure, I think probably you know how long it takes to close the aortic valve by half. So what you see here, and when you're actually measuring pressure half time, you need to bear in mind that vessel's velocity at least have to be 4 centimeter. And if this is somebody with chronic severe aortic regurgitation, if you look at this one, this steps fall so rapidly and come into the baseline. This is somebody with acute AR, and this is somebody with chronic aortic regurgitation. And this is suprasternal. I mentioned the suprasternal view is quite useful. It's a holodiastolic. You can see holodiastole and flow velocity is more than 20 centimeter. You see very specific marker of severe aortic regurgitation. And also like if you holodiastolic reversal of abdominal aorta, you actually can do subcostal window view. So if you see that, that's a specific for severe aortic regurgitation. So this is PISA. We routinely do PISA for all our patients. So what you need to do PISA, you see the jet and it's coming through, and this is the jet, and you measuring. You are actually measuring jet there, and you can see the PISA radius. You're measuring that. You actually you can see your machine will calculate that regurgitant orifice area. And this is how actually you get information about that. So this is somebody with aortic regurgitation. I'm not going details of it. It's presented to 2-3 and AVF segment elevation. On scanning, we found that he has got, and this is what you see is the dissection. You need to bear in mind that dissection can present with loop T3 and inferior wall MI. We shouldn't always look for seeing any changes in ascending aortic dilatation. So acute AR, what you need to do, so if you suspect, and one of the problem in the acute AR is a rapid increase in end-diastolic diameter, and shape is always normal. This is somebody I wanted to show you. This is, I don't think I have enough time for that. So gradient of the severe tube aortic regurgitation. So it's just not only what you are doing assessing in 2D or 3D or 2D method, or you need to actually put everything together. You need to put part morphology is normal, then you need to put color flow AR jet width, and you need to put down continuous signal AR jet, and also semi-quantitative you need to do vena contracta. It is less than 3, and that is my...
Sir, time is up.
Yeah, okay, that's my last slide. And so if I put together everything in, like in philosophy, in combining echo, some core values that embedded in your character, you can't change it. In some attitude, it changes over time, and combination of both is like core behavior. So if we put together everything here, our core value, the way we assess valve, we cannot change all these theories. What is changeable, like the guideline, they updated regular. Then also in maybe guidelines is like USA updating guideline. In future, I think probably artificial intelligence will take over lots of things in assessing our valves, and that could be changed over time. And our core values are, when you combine both of these, then I think probably we could have better valve assessment. Thank you very much. My apology to taking a couple